Assalamualaikum. We are from Group 8. We'll be presenting the case-based learning of the topic of iron poisoning. So, a treating doctor has called for advice. This case involved a 3-year-old boy. He has ingested 50 milligram per kilogram of elemental iron 2 hours ago. He vomited once. Then his parents brought him to the emergency department for assessment. Then an abdominal X-ray has been performed confirming the ingestion. But he now looks well and has age-appropriate vital signs. Firstly, for the risk assessment of iron toxicity. So mainly the risk assessment for iron toxicity is based on the dose or the amount of the elemental iron ingested as well as the clinical features that has been observed. And iron preparations are available most commonly in the form of iron salts. So the amount of the elemental iron in each preparation varies depending upon the salt form. For example, from the table we can see that ferrous fumarate contains 30% of the elemental iron. Therefore, it is important to check what formulation of iron salts. However, in this case, it doesn't mention what formulation of iron salt, but it has mentioned specifically that this patient has ingested 50 milligram per kilogram of elemental iron. Next is the clinical features that can be observed based on the amount of elemental iron that has been ingested. The ingestion of less than 20 milligram per kilogram of iron, the effect are expected to be asymptomatic or no symptom. But for 20 to 40 milligram per kilogram of ingestion, GI symptoms are expected. And for 40 to 60 milligram per kilogram of ingestion, only GI symptoms as well. But systemic toxicity is also not expected. But for 60 to 120 milligram per kilogram of ingestion, are potential for systemic toxicity. And lastly, for ingestion of more than 120 milligram per kilogram, it is potentially lethal. Moving on to the mechanism of iron toxicity. In normal mechanism, iron absorption occurs in the duodenum of small intestine. However, with larger iron doses, for example from iron toxicity, these large amounts of unabsorbed iron can cause the gastrointestinal mucosa inflammation and increase free radical production and peroxidation in the gut mucosa. This then may result in the gastrointestinal side effect such as vomiting, diarrhea, and many more. And potentially, if the gastrointestinal side effects are severe enough, it may cause significant fluid and or blood loss, which can lead to hypovolemia. The disruption of this GI mucosa barrier also leads to increased passive absorption of the iron, in which free iron will quickly saturate the transport protein. Then the free iron enters cells and concentrate in the mitochondria, which may cause impaired oxidative phosphorylation and mitochondrial dysfunction, which can result in cellular death. This oxidative injury then may directly lead to subsequent metabolic acidosis. And because iron is stored in liver, the liver is one of the organs that will be most affected by this cellular iron toxicity. However, the other organs such as the heart, kidneys, lungs, and hematologic system also may be impaired. Next, iron ions can also inhibit multiple reactions that are critical to cellular respiration. This can progress to shock and multi-organ failures. Then, free iron can also directly inhibit thrombin, which can lead to coagulopathy, which is one of the complications of iron toxicity.
Okay, for the toxicokinetic, in short, toxicokinetic is the study of the movement of a toxic substance within the body, including how it is absorbed, distributed, metabolized, and eliminated. It helps in understanding how a substance interacts with different organs and tissues, how long it stays in the body, how it affects the body, and how it can be removed. This information is important in predicting the potential health effects of substance and designing effective treatment strategies for exposure. Okay. For the case of iron poisoning, the toxicokinetic can be described as follows: absorption. Iron typically absorbed in the small intestine, where it is transported across the intestinal lining and into the bloodstream. The rate of absorption depends on the form of iron ingested and the presence of the other substance that can affect iron absorption, such as food or other medication. Next is distribution. Once in the bloodstream, iron can be distributed to various organs and tissues in the body. The liver, spleen, and bone marrow are particularly susceptible to iron accumulation. Next is metabolism. Iron is metabolized in the liver, where it is converted to a form that can be stored in the body, which is ferritin, or excreted, which is heme. In cases of iron poisoning, the liver may become overwhelmed by the high levels of iron and leading to liver damage. Finally, it is elimination. Iron is excreted from the body primarily through the feces, with smaller amount excreted through the urine and sweat. In cases of iron poisoning, chelation and therapy may be used to remove excess iron from the body by binding to and removing iron from the bloodstream. Okay, it is important to note that the toxicokinetic of iron poisoning can vary depending on the individual, the amount of iron ingested, and the time it takes to receive medical attention. Okay, next is the clinical cause of iron poisoning. Okay, it is typically occur in 5 stages. Okay, stage one, which is within 6 hours of overdose. Okay, the symptoms include vomiting blood, diarrhea, abdominal pain, irritability, and drowsiness. If poisoning is very serious, rapid breathing, rapid heart rate, coma, unconsciousness, seizures, and low blood pressure may develop. Okay, for stage two, it occurs within the 6 to 48 hours or after the overdose. Okay, this person's condition can appear to improve, which is usually called the latent phase. Okay, next is the stage three. Stage three occurs within 12 to 48 hours after the overdose. Uh, uh, Usually, the symptoms are very low blood pressure, which is shock, fever, bleeding, jaundice, liver failure, metabolic acidosis, and seizures can develop. Okay, next is stage four, which is usually occur 2 to 5 days after the overdose. The liver may fail, and the people may die from the shock, bleeding, and blood clotting abnormalities. Sugar levels in the blood can decrease, and confusion and sluggishness, which is lethargy, or coma may develop. And lastly, it is stage five. It usually occurs within 2 to 5 weeks after the overdose, and the stomach or intestine can become blocked by scars. Scarring in the organ can cause crampy abdominal pain and vomiting. Severe scarring of the liver, which is cirrhosis, can develop later. Okay, that's all from me.
Moving on, looking at the investigations that are useful in iron poisoning. First investigation is patient history information, which is essential for determining the significance of iron ingestion and directing further management. First question is what type of iron was taken and how much. One determinant of the severity of an overdose is the amount of elemental iron that was ingested and the formulation of iron. Second question is when did the ingestion occur? Symptoms of iron intoxication generally develop soon after ingestion. Patients who have not developed symptoms within 6 hours are unlikely to have ingested a significant amount of iron unless they have ingested an enteric-coated preparation. The third question is, was the ingestion intentional or unintentional? The intentional ingestion, whether as a suicide attempt or as a form of child abuse, is more likely to be significant. The fourth question is, did the patient have access to other toxic substances? Lastly, for children, are there other children at home who could have also ingested iron? The second investigation is the serum iron level interpretation. So the measurement of a peak serum iron level is useful for confirming the diagnosis of iron ingestion. It may also be helpful in predicting serious toxicity, but only if blood samples are drawn at the appropriate time, which is 4 to 6 hours after ingestion of regular iron formulations and 8 hours after ingestion of extended release iron. Peak serum iron levels typically correlate with the following levels of toxicity after oral iron overdose. Less than 350 microgram per deciliter correlates with minimal toxicity. 300 to 500 microgram per deciliter correlates with mild to moderate gastrointestinal symptoms. More than 500 microgram per deciliter correlates with serious systemic toxicity. And more than 1000 microgram per deciliter correlates with significant morbidity and mortality. However, the correlation of serum iron level with the severity of iron intoxication is not exact because it measures free iron circulating in the blood, when it is actually in the intracellular iron that causes systemic toxicity. It is reported that there is no test, including the serum iron level, that is superior to the clinical status of the patient for determining the severity of iron ingestion. Third investigation is the plain radiograph of the abdomen. The presence of radiopacked pills in the stomach confirms the ingestion of iron and is used to determine further management. Radiograph is required in patients with any symptoms of poisoning, patients that ingested an unknown amount of iron or estimated ingestion of more than 40 mg per kg of iron, and patients with intentional ingestion of. The last investigation is the lab evaluation. The purpose of the lab evaluation is to confirm the diagnosis of iron poisoning, to monitor for clinical effects such as metabolic acidosis, liver injury, coagulopathy, and anemia. Firstly, asymptomatic patients who have ingested more than a trivial amount of iron require observation for the development of symptoms and measurement of a peak serum iron level. Asymptomatic patients at risk for toxicity also require prompt measurement of plasma glucose, serum electrolytes, blood urea nitrogen and creatinine, and also venous or arterial blood gas at the time of presentation. Asymptomatic patients with a peak serum iron level of more than 500 microgram per deciliter or the presence of a high anion gut metabolic acidosis require treatment with deferoxamine and measurement of alanine aminotransferase, aspartate aminotransferase, and total complete blood count with differential, prothrombin time, partial thromboplastin time, and international normalized ratio. These patients should also undergo an emergency plain radiograph of the abdomen. As for symptomatic patients, they require the following lab studies according to the degree of poisoning. For mild poisoning patients, they require lab evaluation of plasma glucose, serum electrolytes, blood urea nitrogen and creatinine, venous or arterial blood gas, and peak serum iron level. For moderate to severe poisoning patients, they require all studies as above for mild poisoning, and alanine aminotransferase, aspartate aminotransferase, and total bilirubin, complete blood count with differential, prothrombin time, partial thromboplastin time, and international normalized ratio. All symptomatic patients should also undergo an emergency plain radiograph of the abdomen. So from me, thank you.
Next, question 6. Describe the indication, administration, and potential adverse effect of the antidote that can be used in iron toxicity. Usually, in case of serious iron toxicity, we will give deferoxamine, a chelating agent, as an antidote. So basically, deferoxamine exerts its action by binding to the ferric iron in the blood in order to form water-soluble ferrioxamine, and lastly, it will be eliminated in the urine and appear as orange to reddish-brown color. This antidote should be given as soon as possible if there is any potential serious poisoning, and also it is recommended to give this antidote if there are severe symptoms, if the peak serum iron level is greater than 500 microgram per deciliter, if the estimated ingested dose from visible pill on the radiograph is more than 60 mg per kg, and if there is metabolic acidosis. Next part, administration. Initially, deferoxamine will be administered as continuous IV infusion at 15 mg per kg per hour, then incrementally increased by 5 to 10 mg per kg per hour every 2 to 4 hours. Maximum dose will be 35 mg per kg per hour. And normally, we will increase the dose if there is persistent presence of reddish brown color urine, presence of organ failure, and persistent or worsening of metabolic acidosis. Next, potential adverse effect of this deferoxamine therapy include hypertension and acute respiratory syndrome. Hypertension may occur due to the rapid infusion of deferoxamine and histamine release. Meanwhile, for acute respiratory syndrome, it may occur if patient receive continuous infusion of deferoxamine for 32 to 72 hours or more, but the exact etiology of non-toxicity is actually unknown.
For the early management of iron toxicity, initiating patient stabilization or providing supportive care is crucial. Airway protection, respiratory support, and establishment of IV access should be provided as needed. Circulation should be assessed by continuous monitoring of pulse rate, blood pressure, urinary output, and evaluation of peripheral perfusion. Second, volume resuscitation. It is indicated to maintain euvolemia due to hypovolemic shock, which is the major cause of mortality during the first phase of iron intoxication. Patients who present with severe gastrointestinal symptoms require urgent intensive management to maintain effective circulating blood volume. Normal saline should be administered in boluses of 20 ml per kg as necessary to improve perfusion, tachycardia, and to maintain blood pressure. Next, although uncommon, serial measurement of hemoglobin is indicated for pediatric patients with serious upper GI bleeding to determine the need for transfusion therapy, and they need to consult with pediatric gastroenterologists. Continue with the types of decontamination indicated for iron toxicity. There are several options for decontamination for iron toxicity. First, whole bowel irrigation with polyethylene glycol solution may clear the GI tract of iron pills before absorption and should be administered at 250 to 500 ml per hour in children and 1.5 to 2 liters per hour in adults via nasogastric tube. Next, orogastric lavage. Orogastric lavage with normal saline via orogastric tube may be indicated for patients with moderate to severe iron poisoning and large amounts of iron still unabsorbed in the stomach. Gastric lavage carries a significant risk of complications including aspiration, esophageal or gastric perforation, and laryngospasm. Patients who cannot protect their airway require rapid sequence intubation prior to the procedure. Lastly, upper GI endoscopy or surgical gastrotomy. Iron tablets may become embedded in the gastric wall, forming concretions that are resistant to lavage or whole bowel irrigation. In such cases, endoscopy or surgical gastrotomy may have benefits, especially when clinical toxicity persists. Case reports have described surgical removal or alternative endoscopic removal of iron from the stomach may be attempted for pill concretions that could not be removed with other methods. But distillation therapy along with the supportive care should be continued. It should be reminded other options for decontamination that should be avoided is decontamination by activated charcoal because it binds iron poorly and is ineffective. Syrup of ipecac to induce vomiting is ineffective in general, and iron ingestion frequently causes spontaneous vomiting. Gastric lavage with bicarbonate or phosphate solutions should be avoided because of large volume of bicarbonate necessary to achieve the effect and reports of phosphate poisoning. Then, gastric lavage with deferoxamine should be prevented because of the large volumes of deferoxamine is required in an overdose case to have any appreciable effect. And lastly, catharsis via the administration of magnesium-containing preparations because it is ineffective. Therefore, in this case, decontamination may not be indicated for this patient. This is because he ingested 50 mg per kg elemental iron and had vomited. According to this algorithm, this patient is having mild poisoning symptoms. Hence, this patient should be monitored for 6 to 12 hours in an acute care setting. If the symptom is worsening, deferoxamine can be administered. If the symptom is not worsening, the patient may be discharged. That's all from us. Thank you.